to start the next session. So the next session is, so for the first, we have seen how we can make a radiopharmaceutical, especially theranostic radiopharmaceutical, and how to pass through the government like KFDA and how to be approved, how to get the IND approval. So next is then how these clinically approved drugs are applied in a clinical situation will be discussed in this session. So I'm a medical doctor in Seoul National University, and my name is MS Suh again. So again, I want to show you that these radioactive drugs emerges from the shadows to storm the market. And recently, the Novartis paid $2.1 billion to Endocyte to buy the PSMA ligand drug, and also previously shown that the Novartis also paid a $3.9 billion to AAA for the lutetium dotatate drug. So the part why I am keep showing this kind of emerge from the market is that because previously we already have some clinically approved drugs such as Jevalin or Bexar, which is yttrium or iodine-based therapeutic agent for non-Hodgkin lymphoma. But as you can see, this Bexar has withdrawn in 2014. And Jevalin also is not well widely used. And the reason, although these radiopharmaceuticals have proven a great clinical efficacy, the reason some have disappeared from the market is because the big pharmaceuticals are not actually have interest in this radiopharmaceuticals. So there is less and less pay for this or less interest in this products. However, interestingly, and which is promising, is that now big pharmaceuticals are paying attention to this therapeutic radiopharmaceutical. Bayer has actually paid for the Xofigo and Novartis for LUTATHERA, and this Endocyte also, Novartis has paid for this drug. So these are some latest candidate drugs that are in the market. So in this session, I would like to show some clinically approved or which are in the clinical trial or some newcoming agent. So first will be about the neuroendocrine tumors. So this neuroendocrine tumor was first commented by this German doctor, and it was commented on the tumors of the small intestine, and it was coined as a term carcinoid, and which is also used nowadays also. And this neuroendocrine tumors begins in the hormone producing cells of body's neuroendocrine system. And it is known to be frequently unpredictable and have an unusual biological behavior and are frequently present late after delayed diagnosis. The types of neuroendocrine tumors can be divided where it comes out. And the most prevalent site is actually the small intestine, and like midgut is the most prevalent site. And we can actually classify these neuroendocrine tumors by the WHO classification by well differentiated or moderately differentiated by these appearance and mitotic rate and Ki-67 index. And these different grade has different prognosis. But a challenge in this diagnostic and therapeutics of the neuroendocrine tumor is that these tumors has a very heterogeneous group of tumors. And so the clinical presentation is very variable. And also, as previously mentioned, the presentation of the neuroendocrine tumor is late. Like over 60% of neuroendocrine tumors are advanced at the time of diagnosis. And the median survival for patients with advanced neuroendocrine tumor is 33 months. And because there are many sites of these tumors coming out, and there are different terminology and classification. So as we know, carcinoid tumor and pheochromocytoma and just neuroendocrine tumor are all neuroendocrine tumors, but how to manage and to treat has a very diverse, and the clinical presentation is also diverse. And right now, there is an increase of the neuroendocrine tumor worldwide. And although this is until 2005, until 2020, there is an increasing of these disease. And actually, the growth of this malignant neoplasm is this growth of the neuroendocrine tumor actually has exceeded the growth rate of the malignant neoplasm. And for the diagnosis of these neuroendocrine tumor, we can use a blood markers, or there are new potential markers which are using microRNAs or circulating tumor cells. And image studies can be applied for the diagnosis, such as for the anatomical image, such as CT or MRI can be used. And for the functional imaging, somatostatin analog imaging, such as octreotide scan and gallium dotatate PET can be used. And for the final and diagnosis, the histological diagnosis is used, and we evaluate the differential grade of the tumor by this histological diagnosis. And as shown, this neuroendocrine tumor has a characteristics of high expression of somatostatin receptors. The somatostatin is produced in the hypothalamus and has a multiple biological functions. And there are 5 types of these somatostatin receptors. However, the major subtypes in the neuroendocrine tumor, which is highly expressed, is somatostatin receptor 1 and type 2. And nextly, there are several therapeutic options for this neuroendocrine tumor. So firstly, we can do the surgery. But after the surgery, there are many options. Firstly, the conventional methods are related to these somatostatin analogs. And these include octreotide, which is the sandostatin, and lanreotide, which is somatulin. And there are chemotherapies, such as FOLFOX or platinum-based chemotherapy can be used. And also recently, there are targeted therapies which shown an effect in the management of neuroendocrine tumor, which is a Everolimus or bevacizumab or sunitinib. And lastly, there is there is recently approved PRRT, which is the lutetium DOTA or yttrium DOTA somatostatin analogs. So as you can see in the consensus guideline of these neuroendocrine tumor for the advanced and local regional disease or with distant metastasis, the first line therapy actually is the somatostatin analog. And for now, after the treatment of the somatostatin analog, if there is still a progression, and if it does not work, there are many options right now for the neuroendocrine tumor patient therapy, and there is no one consensus right now. And as you can see, the PRRT also is included for the second-line therapy. So as I mentioned, after the clinical approval for the worldwide use and to survive in the market, it is important to be transferred into the guideline. And now, because these ENETS or in the Neuroendocrine Society, there is a consensus that the PRRT is effective. It is in the guideline, as you can see. And regarding other therapeutic agents that are used in the neuroendocrine tumor management, the first line therapy right now is the somatostatin analog. And these somatostatin analog can have various effects in the neuroendocrine tumor. It can reduce the apoptosis or growth and proliferation of the tumor cells. And even also, it can regulate the secretion of this tumor. And also, it can have an effect in the angiogenesis by regulating the protein synthesis. So this is used for the first-line drug. However, there has been some targeted drugs right now, which is the Everolimus, which is the mTOR inhibitor, and some other drugs like sunitinib or bevacizumab, which actually has an effect in the endocellular cells or pericyte to inhibit the angiogenesis and the proliferation of the tumors. And these drugs has proven its efficacy by the ongoing or already completed phase 3 studies. So as you can see, these all drugs have been transferred to the clinical guideline. So these are some summary of the clinical trial landscape in neuroendocrine tumor, which has been completed right now. And these have somewhat different, these trials use somewhat different drug and target. However, they are proposed for the second line drug, which has progressed after the application of the somatostatin analog. So as you can think, these drugs are some competing drugs with the PRRT and lutetium dotatate right now. But actually, there are some limitations of the randomized or placebo-controlled trial using the previous trials has some limitation using this targeted therapy because it has some limitation to impossible to compare the outcome of one study to another because it uses a different drug and different target. And actual overall survival is difficult to assess since these results are confounded by high crossover rate. And also data from placebo indicate it can be much feasible in patients with low risk profiles such as grade 1 or low tumor burden. And with these targeted drugs, they neither achieve cure nor high objective remission, but they acquire stable disease state. So we introduced a peptide receptor radionuclide therapy known as PRRT, and this molecular therapy is used in the neuroendocrine tumor, and it is currently being investigated as a treatment for the prostate and pancreatic tumors. And this cell targeting protein, it uses a octreotide, which is a somatostatin analog, and they put a therapeutic radioisotope on it. And so they can use it as a radiopharmaceutical for therapy. So for the radioisotope, they use yttrium or lutetium. And so this lutetium dotatate for the mid-gut neuroendocrine tumor has actually shown a very promising result, both in the progression-free survival and overall survival, and has got an approval for the FDA. Then, what is coming next for this lutetium dotatate or PRRT? So there are new randomized controlled trials, and other prospective trials are ongoing for broadening the indication of this drug. And there should be a comparison with these targeted therapies such as Everolimus or bevacizumab or sunitinib. But still, there are no comparison data yet. And some new validation of new therapeutic strategies are now being in a clinical trial, such as combination therapy and selective intra-arterial injection, or using the alpha emitters instead of the beta emitters. And also somatostatin antagonists are used. So first, for the broadening the indication, as you can see, the NETTER-1 trial was for the patient who has no response to the conventional somatostatin analog. And they showed a very promising result. However, the NETTER-2 trial is actually having a goal for a patient who have metastasis or locally advanced neuroendocrine tumor, but who have not undergone chemotherapy or other targeted therapy. So this NETTER-2 trial is actually targeting for the first-line therapy. And as you can think, if compared to the second-line therapy, if you come to the first-line therapy in the guideline, the patient indication can be significantly broadened. So this is the goal of this NETTER-2 trial, which is now done in worldwide, including Europe, America, and China, and also South Korea. And it is now, sooner or later, it will be started in Korea. And next is about the comparison with the targeted therapy. So right now, there are many choices of second-line therapy for neuroendocrine tumor. And there is no data which therapy has a better effect. And now there is a COMPETE trial, which is the phase 3 trial, comparing the Everolimus and lutetium-177 in worldwide, and like 11 countries are participating, and they will recruit more than 300 patients. And actually, this if this result comes out, it may change. It may have an impact in changing the guideline, whether we can survive in the second line or we can be the only one for the second line therapy. And there are also other trials coming up, which is combining the PRRT with PARP inhibitor, and also as a TACE, since the neuroendocrine tumor has many liver metastases, intra-arterial injection, some think that these intra-arterial injection of the PRRT may have more effect and less toxicity to the patient. And there are also attempts using the alpha particles, and also somatostatin antagonists are tested whether it has a better effect compared to the conventional the somatostatin analog labeled with the therapeutic radioisotopes. So upcoming results of these these clinical trials will make more opportunity and more diverse usage of these radiopharmaceuticals. And as you can see, there has been a introduction of using the alpha particle for the therapy of the neuroendocrine tumor. So now I will move on to the prostate cancer. So prostate cancer is a very emerging tumor right now worldwide. And the 10 or 20% of men have advanced prostate cancer at the time of diagnosis. And more than 40% eventually progress to metastatic castration-resistant prostate cancer, which is known to be mCRPC. And these resistant prostate cancer is considered the lesser phenotype of prostate cancer and is defined as disease progression despite other pharmaceutical or surgical castration. So standard treatments are systemic taxane chemotherapy and anti-androgen pharmaceuticals and an antibody which blocks the interaction between the tumor's tissue and bones are used in these patients. However, these the response rates of these standard treatment are still low for the treatment of these the mCRPC patients. So there is a new candidate, a new target, which is known to be the prostate-specific membrane antigen, PSMA. And these are mainly expressed in prostate cancer and tumor-associated neovasculature. And it is highly expressed at all stages of the disease. And it is also upregulated in androgen insensitive or metastatic diseases. And it is expressed on the cell surface as an integral membrane protein and not secreted or released after internalization. So using this ligand, people have put a labeled a therapeutic radioisotope and made a lutetium PSMA 617, which is the most famous and which has gone most further to the phase 3 clinical trial right now, has been introduced. And as you can see, this is a reported a phase 2 study of this lutetium PSMA. And they put the primary endpoint as a PSA response. And 50% of PSA response, they defined it as a response. And for the secondary endpoint, they have put a radiographic progression or quality of life. And they found out that these lutetium PSMA has high response rate and also, as you can see, very low toxicities. But the most frequent toxicity with this lutetium PSMA was xerostomia, which is known to be a dry mouth. And actually, these PSMA has a high uptake in this salivary gland. There are also concerns how to protect the salivary glands from the PSMA therapies. So this has proven its efficacy in this clinical phase 2 trial. And now there is ongoing phase 3 trial, which is known to be the VISION trial. And the design of this trial is one group is the lutetium PSMA with the best supportive care versus the best supportive care in patients which had progressed after the the third line, every standard treatment. So these standard of treatment include any which have previously mentioned about chemotherapies or other antibody therapies. And the primary endpoint is to find out the PFS and overall survival. And if with this trial, if we can prove the efficacy in this VISION trial, this lutetium PSMA may be approved for the third line or fourth line therapy for this mCRPC patients. And there are also some ongoing clinical trials of comparing this PSMA agent with the chemotherapeutic standard therapeutic agent. And these kind of comparison with the standard treatment may broaden the indication of these PSMA therapeutic agents to more upward to the second line or third line therapeutic choice. And there are also a combination with the PARP inhibitor and this PSMA, lutetium PSMA, and also some are doing immunotherapy with this PSMA radionuclide therapy. However, this lutetium-based PSMA agent has a, for now, have shown a efficacy near 45% of patients had a biochemical response to PSMA ligand. And 40% did not have any response. So, and also these PSMA has shown a diffuse red marrow infiltration. And because the prostate cancer patient has frequently has a disseminated bone metastasis, this can end up a bone marrow, red marrow toxicities. So as you can see in the blood test, and there has been many have shown a quite high percentage of leukopenia or anemia or thrombocytopenias using this lutetium PSMA agent. So now people have introduced this actinium PSMA, which is using the alpha particle. And because it has a shorter energy range, it may have a less effect in the adjacent bone marrows. So, and also it has shown proven a more effective in some cases. As you can see in this case, this patient had 2 cycles of lutetium PSMA therapy, however, had no significant response. And PSA level actually increased after the therapy. However, after the actinium therapy, this patient was relieved. But for these, so there are ongoing studies for this use of alpha particle for the PSMA, and some clinicians are have an hypothesis that this alpha particle may have more promising results for, especially for the PSMA. However, still, using this both lutetium-based PRRT and Dotatate or PSMA therapy, there are some concerns of after the therapy, how are we going to evaluate the treatment response? Because there are some concerns. After the lutetium therapy, there has been some reports that the somatostatin receptors, although is the presentation of the somatostatin receptor actually decreases if the tumor goes dedifferentiation. Then although the tumor progresses in the gallium dotatate image, the uptake level of the dotatate may be seen a decrease, but the actual disease have progressed. So that kind of issues are now having concern, and many consensus reports are coming out how to evaluate the response of these neuroendocrine tumors or prostate cancer after this kind of radiopharmaceutical therapies. And next is about personalized dosimetry. Although we think that personalizing the dosimetry and adjusting the dose is important, but still there are some issues, but we used a fixed dose for the therapy. And to apply these personalized dosimetry, we need more evidence. And I think these kind of issues as an advertisement will be discussed in our winter TEIN workshop. So this was some summary of the neuroendocrine tumor and PRRT used in the neuroendocrine tumor and prostate cancer. And lastly, I want to discuss is about the emerging target, which I think may be most promising. So we have currently discussed about this dotatate and PSMA. However, there are new fibroblast activation protein. So this cancer-associated fibroblast is and this tumor actually consists of fibroblasts, and these stromas account up to 90% of the mass. And these cancer-associated fibroblasts has many effects of tumor progression from metastasis, angiogenesis, and metabolism. And targeting these cancer-associated fibroblasts, there is a fibroblast activation protein. And this FOB is a transmembrane cell surface proteinase and degrade proteins of the extracellular matrix, and it is actually upregulated in the cancer. And it is highly expressed on the cell surfaces of activated fibroblasts. And the expression in the normal tissue is actually very low. So FOB can actually target a broad range of tumors because these cancers actually have high expressions of this FOB. And it is known that more than 90% of epithelial cancer actually express this FOB. And this can be a potential cancer target. So people in the Germany Heidelberg group has recently developed a quinolone-based FOB inhibitors and put a diagnostic radioisotope for the imaging. And as you may have seen, labeled with this gallium agent, the gallium-68 FOB PET showed very promising result of a high lesion to background of the tumor imaging. And it also have shown it can be used in the broad range of cancers. And actually, this FOB targeting images has some advantages because it can detect a FDG low avid tumors, and also it has a early imaging. It can be acquired in an early minute, and it doesn't need any kind of preparation which is needed for the FDG imaging. So because of these success of introduction of this FOB, there has been an attempt to label with the radiopharmaceutical for the therapeutic purpose. And in the same group, some group have introduced labeling with the yttrium and have shown a therapeutic effect of these yttrium labeled FAPI with no side effect. So there are some clinical trials for the gallium labeled FAPI, however, not yet for the therapeutic agent. But near future, there will be a therapeutic attempt for the therapeutic clinical trial for this PAPI agent. And because of its diverse application, it may have a significantly increase the application of this agent. And the last thing I want to share is that in Korea, actually, from the first in-human study of this lutetium-177 Dotatate to the first clinical trial in Korea, it took 20 years. And for the lutetium PSMA, from the first in-human study in Korea for the clinical trial, it takes 5 years. But because we are having more interest in applying this lutetium or therapeutic agent, now we can actually reduce the time and reduce the gap of this therapy. Although these agents were not actually developed, firstly developed in Korea, but we can fastly chase up for this application in the clinical situation. And I think this is actually also can be applied to the Indonesia situation. So thank you for thank you. And this is the last slide of my presentation. So if you have any questions or comments, please freely have. So if there is so I got a question from Elian T. I'm not sure I pronounced well, but that which might be better for PAPI, like for the beta or the alpha particle. I think it may be quite different for what kind of tumor we are dealing with. So actually, it is known for a tumor, very large tumor burden patient. Actually, because of the range, the beta radiopharmaceutical might have better effect. And for more small tumors, or disseminate tumors, it is some says that these alpha particles may be better. So for now, I should answer that it will be different according to the patient type or the tumor type. But more validation studies will come out using from the PSMA or neuroendocrine tumor studies, which might answer the question. So I also want to hear if there is any activity or to plan to apply these therapeutic agent in Indonesia. If someone can share some circumstance, it will be great for us.
Yes, Dr. So we have performed PRRT for one cycle for iodine refractory thyroid cancer. So we have performed it once, but the subsequent cycle is postponed due to the COVID pandemic. So the supplier cannot deliver us the lutetium. So we are still waiting for the second cycle.
I see. How about just for the previous, is there some regulation issues in Indonesia to apply this, to introduce this the therapeutic agents?
For this trial, we have the license from our ethical committee from our hospital. So it's not so it's just still in clinical trial. So they let us do it, but we haven't done from other than from thyroid cancer.
So I think if you can pass the IRB, there is a chance to apply these radiopharmaceuticals. And I think then it may be some opportunity for the fast chasing, I think, for the fast application of these radiopharmaceutical agents. I think the regulation actually can be actually help for the safety of the patient, but actually can be it may be an obstacle for the development or other some issues. So thank you for your comment.
Actually, Dr. Suh.
Yeah.
So continuing Dr. Aisha Elianti's question. So actually, her question would be expanded to another question that I still wonder why actinium the dotatate was working in the patient with lutetium. The dotatate was not effective. Would you please elaborate the difference between actinium and lutetium in that case? So why I said my question, following question is the continue in the Asia's question is because FAP, the fibroblast activation protein, is actually not on the cancer. So in that case, actinium, which has a very short range, is going to be effective in cases with the lutetium would be effective. So even though in case of the prostate cancer, actinium would have been effective, prostate or the neuroendocrine tumor would have been effective, but in case of FAP, radionuclide therapy, the reverse would be true.
I think good, actually good point of since this FAP is not is actually more is abundantly expressed in the stroma and in not the tumor cell itself. Actually, as you have mentioned, that lutetium therapy may have more effect. But regarding the case, this case of why this patient had a effect more in using the actinium, I would want to have some share from the Professor Yoon Sang Lee if he
Actually, I think theoretically that the range of actin 2 to 5, therapeutic range of actin 2 to 5 should less than the lutetium 177. But we don't know the why that actin can have a dramatically effective in some cases. So still they struggle for to find the reason why. But still we don't know yet.
So to help the audience to have the question regarding the reports in the literature, the same question had occurred to to our minds 20 or 30 years ago. Samarium or strontium therapy were not effective in the disseminated bone metastasis patients. However, the recent introduction of alpha emitter was effective. So there was another question. So why? Why the cancers are metastasizing to the bone, at first in the bone marrow, and then the encroaching bones. So the people, just like me, as a simple thinker, just simply thinking at the range, the more extensive range, expansive ranges would be helpful, but it was not the case. The alpha emitter was better than the beta emitter in case of the disseminated bone metastasis. So the same thing happened in case of the prostate cancer, and I wonder the FAP, radionuclide therapy, is going to be working in the same way or in a reverse way. So let's see. Because I'm not in the field of my expertise is not the cancer therapy. However, as a nuclear medicine physician, I'm curious. So even though there is no answer in the literature, and even though we cannot speculate the reason why, then let's bear this question in mind so that afterward we can understand.
So, moving on to the next question, there has been question about pre-therapy dosimetry for the trial of lutetium or PSMA. Actually, most of trials, they are not doing the pre-therapy dosimetry and they are just using the fixed dose. However, there has been a concern for person and the use of actual dosimetry. There are some studies using for the monitoring, as you have answered for the next question. It has a role. There are some trials ongoing to test whether it has a role for the follow-up and monitoring. And what they do is after the first treatment, they do the dosimetry and they calculate the dose in the critical organs. And if it is high, the purpose is to adjust. Or if it is low, the purpose is to more up-level the dose, which the patient can tolerate. So they are now going to see whether adjusting these dose in a personalized manner might help the patient. But still, most of the trial or clinical situation, we used a fixed dose. And for the question from the Edison, that patient for the lutetium dotatate patient right now, we do clinical trial. They actually there is no regulation to isolate the patient. So in some centers, also including our center, do the lutetium therapy about outpatient in outpatient settings. So actually there is no concern for the isolation of patient, but we give a patient the consensus to get some, to be as like iodine therapy, we just do some caution to the patient to be for like 1 day to be far from families and just like that. But there is no actual regulation because of the low gamma rays or coming out from this lutetium agent. And I think, again, the more about the dosimetry will be, I think, discussed in the winter TEIN workshop. So please, again, participate in that winter session. And before ending up this session, I want to inform everyone, every participant to please participate in the online survey of this workshop. We have put a link in the chatting. As you can see, the second link is the one you can go on and do the Google survey. So please give us the feedback that we can more update our contents for the future collaboration. So thank you, and we will have a we will have a 10-minute break, and we will meet again at 10 minutes later. Thank you.